Bismillahirrahmanirrahim. Quote for the day is and hold firmly to the rope of Allah altogether and do not become divided. This is an ayah from Surah Al Imran. The topic for today's presentation is vitamin B and C. I am Dr. Ayesha Amin, PGR of FCPS Community Medicine at Institute of Public Health, and I will be presenting this under the kind supervision of my supervisor and teacher, Professor Dr. Saira Afzal, who is the Dean of IPH Lahore. The learning outline for today's presentation would be Introduction to Vitamin B and C, Dietary Sources and Function, Important Clinical Syndrome of Vitamin B and C Deficiency, Public Health and Preventive Aspect, Recent Updates, and Multiple Choice Questions. Learning objective. By the end of this presentation, the participants will be able to describe the brief introduction of vitamin B and C, their importance, deficiency syndrome associated with them, their prevention, and to be able to answer the multiple choice questions. So coming to the vitamin C. Vitamin C, which is also known as ascorbic acid, is a water-soluble vitamin essential for the normal growth and maintenance of body tissues. Human cannot synthesize vitamin C due to the absence of the enzyme L-gluconolactone oxidase. Therefore, it must be obtained through the diet. It is the most sensitive of all vitamins to heat. Prolonged storage, cutting, and cooking can significantly reduce vitamin C content due to oxidation. Functions. The important functions played by vitamin C are collagen synthesis. It is essential for the hydroxylation of proline and lysine, maintaining the integrity of skin, blood vessels, bones, and connective tissue. Wound healing. It promotes tissue repair and scar formation. Antioxidant action. It neutralizes free radical, protects cells from oxidative damage. It helps in iron absorption. It enhances the absorption of non-heme iron by reducing ferric to ferrous form. Immune functions. It supports resistance to infections, enhance leukocyte function. Metabolic function. It involved in the synthesis of the neurotransmitters such as norepinephrine, and it participates in the metabolism of certain amino acids. Sources of vitamin C. The vitamin C can be obtained from fruits and vegetables. The fruits which are rich in vitamin C are mainly the citrus fruits like orange, lemon, grapefruit, guava. Amla is the richest source of the vitamin C. Then there are strawberries and papaya. The vegetables which contain vitamin C are green leafy vegetables, tomatoes, capsicums or bell peppers, broccoli, and cabbage. In this table, we can see that the dietary sources of vitamin C, and we can see in the list of fruits, the amla, it has the highest concentration of vitamin C. It contains 600 milligrams of vitamin C per 100 gram. And in vegetables, followed by guava and then lime and orange. And in vegetable, the cabbage contains the highest content of vitamin C. The estimated requirement for the vitamin C is 40 milligrams per day for adults. The normal body, when fully saturated, contains about 5 grams of vitamin C. The deficiency of vitamin C can lead to the scurvy. Vitamin C deficiency results in scurvy, which is a condition caused by an inadequate intake of ascorbic acid, leading to defective collagen synthesis and increased capillary fragility. The history of scurvy. Scurvy is a disease of vitamin C deficiency plagued to humanity for millennia, devastating ancient armies and especially sailors on the long ways, causing horrific symptoms like bleeding gums and extreme weakness. Its history moved back from the ancient records of Egypt and Hippocrates to mass casualties during the age of sail, prompting Surgeon James Lind's 1747 discoveries that citrus cured it, leading to the Royal Navy's adoption of limeys and dramatically reduced the death at sea, with the specific vitamin C ascorbic acid identified much later in 1920s. The causes of vitamin C deficiency or scurvy are inadequate intake of fresh fruits and vegetables, prolonged consumption of cooked or stored food, poverty and food insecurity, chronic alcoholism, elderly individuals which are living alone, infants who are fed on boiled or diluted milk without supplementation, and increased requirements during pregnancy, lactations, infections, and after trauma. The clinical features of the scurvy range from journal symptoms to systematic manifestation. The journal symptoms include fatigue and weakness, malaise and irritability, and anorexia. The oral and dental manifestations are the swollen, spongy, and bleeding gums. There can be gingivitis and loosening of teeth, while the systemic manifestations are anemia due to the impaired absorption of iron and lead to bleeding. Then there is delayed wound healing and increased susceptibility to infections. The prevention of vitamin C deficiency, the primary prevention is dietary diversification is an important aspect. Regular consumption of the vitamin C rich foods such as citrus fruits, guava, amla, green leafy vegetables, tomato and capsicum. Nutrition education, promotion of the fresh fruits and vegetable in daily life, awareness about the loss of vitamin C due to overcooking. Proper food handling and cooking practices, avoid prolonged storage, minimal cutting and exposure to air, and use of steaming or light cooking methods. The secondary prevention includes screening of high-risk group, infants, elderly, pregnant and lactating women, alcoholics, and people with poor dietary intake. The early diagnosis, the identification of symptoms such as bleeding gums and fatigue, and then the prompt supplementation is mandatory. Oral vitamin C supplementations to prevent progression of the disease. The tertiary prevention includes the treatment of scurvy, therapeutic doses of vitamin C are given, and then management of complications, treatment of anemia, infections, and wound healing, and dietary rehabilitation. Long-term improvement in diet is needed. The community health awareness measures, there should be the promotion of the kitchen gardens, inclusion of fruits and vegetable in school meal programs, supplementation during emergencies and relief camps, and food security and poverty alleviation programs. The next topic is vitamin B complex. So vitamin B complex is composed of the 8 B vitamins, commonly B1 to B6. The B vitamins are B1 thiamine, B2 riboflavin, B3 niacin, B5 pantothenic acid, B6 pyridoxine, B7 biotin, B9 folic acid, and B12 cobalamin. We will look into the details of all one by one. So the first one is vitamin B1, which is known as thiamine. So again, thiamine is a water-soluble vitamin. It acts as a coenzyme, thiamine pyrophosphate in carbohydrate metabolism, and it is essential for energy production. It is important for the normal nerve conduction. It maintains proper cardiac and muscular function, and it supports appetite and growth. Sources, the thiamine occur in all natural food in small amounts. The important sources of thiamine are whole grain cereals like wheat, gram, yeast, pulses, oil seeds, and nuts, especially groundnut, meat, fish, egg, vegetables. Fruit contains smaller amount. Milk is also an important source of thiamine for infant, provided the thiamine status of their mother is satisfactory. So we can see in this table, the fruits and vegetable, we can see that the wheat, almost all the foods contain thiamine: wheat, rice, um, uh, almonds, groundnut, milks, hen, egg hen, mutton, liver, sheep. Almost all food has thiamine in it. The recommended daily intake of thiamine is the body content of thiamine is placed at 30 milligram, and if more than that is given, it is merely lost in the urine. Patient on regular hemodialysis, they should routinely be given the supplements of thiamine, and thiamine should also be given prophylactically to the people with persistent vomiting or prolonged gastric aspiration and those who go on long fasts. Thiamine losses. The thiamine is readily lost from the rice during the process of milling. Being a water-soluble vitamin, further loss take place during washing and cooking of rice. This is the basis of advising people to eschew high-polished rice and eat parboiled or undermilled rice. Much of thiamine in fruits and vegetable is generally lost during prolonged storage. Thiamine is also destroyed in toast and in cereals cooked with baking soda. So the deficiency of the thiamine, it can lead to the condition known as beriberi. So thiamine deficiency leads to beriberi, commonly seen in population consuming polished rice. The types of beriberi is dry beriberi, wet beriberi, infantile beriberi, and Wernicke's-Korsakoff syndrome. The dry beriberi is characterized by the peripheral neuropathy and muscle weakness and wasting, while the wet beriberi is marked by the cardiac symptoms. It leads to edema and cardiac failure, especially the high output cardiac failure. Then there is infantile beriberi, which is seen in infant between 2 and 4 months of age, occur in breastfeeding infants of thiamine deficient mothers, while the Wernicke's-Korsakoff syndrome or the Wernicke's encephalopathy is seen in patients with chronic alcoholism. This is a picture which is showing the dry beriberi. And the edema, and the picture on the right side is showing the wet beriberi, where there is pedal edema, and picture on the right side is showing the dry beriberi. Prevention: the beriberi can be eliminated by educating people to eat well balanced mixed diet containing thiamine rich foods, e.g. parboiled and undermilled rice. Stop all alcohol. Direct supplementation of high risk groups such as lactating mothers with thiamine and beriberi tend to disappear as the economic condition improves and diet become more versatile. The next vitamin is riboflavin. The riboflavin is a member of the B group vitamins. The function: it has a fundamental role in cellular oxidation. It plays an important role in maintaining the integrity of the mucocutaneous structure. It is a cofactor in a number of coenzymes involved with the energy metabolism. It is also involved in antioxidant activity, and it is required for the metabolism of other vitamins like B6, niacin, and vitamin K. The sources of vitamin B2: the richest natural sources of vitamin B2 are the milk, eggs, liver, kidney, and green leafy vegetables. Meat and fish contain small amounts. The cereals, whether whole or milled, and pulses, they are relatively the poor sources of B2, sorry. Requirement: there are no real body stores of riboflavin, so the daily intake is mandatory. So daily requirement is 0.6 milligram per 1000 kilocalories of the energy intake. Deficiency: the most common lesions which are associated with the riboflavin deficiency is angular stomatitis, which occur frequently in malnourished children, and its prevalence is used as an index of the state of nutrition of the groups of children. This is a picture which is showing the angular stomatitis, the lesions around the corners of the lips. Other clinical signs include cheilosis, glossitis, nasolabial dysbiasia, hyporiboflavinosis. Even when severe, seldom incapacitate the individual, but it may have subtle functional effects such as impaired neuromotor function, wound healing, and perhaps increased susceptibility to cataract. Riboflavin deficiency almost always occur in association with the deficiency of other vitamin B complexes such as pyridoxine. So it is usually a part of multiple deficiency syndrome. The isolated deficiency is sometimes rare. The next vitamin is niacin or nicotinic acid. The niacin or nicotinic acid, or the B3, is the essential for the metabolism of carbohydrate, fat, and protein. It is also essential for the normal functioning of the skin, intestine, and nervous system. This vitamin differs from the other vitamins of the B complex group in that an essential amino acid, tryptophan, serves as a precursor of niacin. Another characteristic of niacin is that it is not excreted in urine as such. The sources: the food rich in niacin or tryptophan, because tryptophan is the precursor of the niacin, are liver, kidney, meat, poultry, fish, legumes, and groundnut. Milk is a poor source of niacin, but its proteins are rich in tryptophan, which is converted in the body into the niacin. About 60 milligram of tryptophan is required to results in 1 milligram of niacin. In many cereals, especially maize, niacin occur in bound forms, and it is usually unavailable for the consumer. So the bound form of niacin is normally of no use requirement. The recommended daily allowance is 6 milligram per 1000 kilocalories of energy intake. Deficiency: the deficiency of niacin, it can lead to pellagra. The disease is characterized by the 3 Ds, that is diarrhea, dermatitis, and dementia. In addition, glossitis and stomatitis usually occur. The dermatitis is bilateral, symmetrical, and it is found only on those surfaces of the body exposed to sunlight, such as back of hands, lower legs, face, and neck. Mental changes may also occur, which include depression, irritability, and delirium. This is a picture which is showing the pellagra, the dermatitis which is associated with the pellagra. So pellagra is a preventable disease. A good mixed diet containing milk or meat is usually universally regarded as an essential part of the prevention and treatment. Avoidance of total dependence on maize or sorghum is an important preventive measure. Pellagra is a disease of poverty. Modern knowledge and opportunities for economic, agricultural, and social development, they should be provided to the communities and people. The next important vitamin is pyridoxine. The pyridoxine B6 exists in the form as pyridoxal and pyridoxamine. It plays an important role in the metabolism of amino acids, fats, and carbohydrate. It is widely distributed in food, for example, milk, liver, meat, egg yolk, fish, whole grains, cereal, legumes, and vegetables. The pyridoxine deficiency is associated with peripheral neuritis. Riboflavin deficiency impairs the optimal utilization of pyridoxine. So they occur hand in hand. The isoniazid, which is a class of anti-tuberculous drug, is recognized antagonist, and the patients who are receiving the isoniazids, they are provided with the supplement of pyridoxine at the dose of 10 milligram per day. The requirement of the adults vary directly with the protein intake. Adult may need 2 milligram per day, and in pregnancy and lactation, the dose can be as high as 2.5 milligram per day. The balanced diet usually contain pyridoxine, so the deficiency of pyridoxine is rare. Except in case if the person is taking anti-tuberculous agents, so they should be provided with the pyridoxine, because these drugs, they interfere with they are basically the antagonist of pyridoxine. The next vitamin is pantothenic acid. The role for pantothenic acid in the biosynthesis of corticosteroids is important. The human blood normally contains 18 to 35 milligrams of pantothenic acid per 100 ml, mostly present in the cell as coenzyme A. The daily requirement is set at 10 milligrams. All foods contribute to dietary intake, and the pantothenic acid about 3 milligrams. It is excreted in daily in urine. The next important class of vitamin is folic acid. So folic acid occur in food in the form of folate and bound folates. The total folates represent both the groups. In men, free folate is rapidly absorbed primarily from the proximal part of the small intestine. The availability of bound folate is uncertain. Folic acid play a role in the synthesis of nucleic acid, which constitutes the chromosomes. It is also needed for the normal development of blood cells in the bone marrow. The sources of folic acid, the names come from Latin word lofia, leaf, but foods such as liver, meat, dairy products, eggs, milks, fruits, and cereals are as good dietary sources as leafy vegetables. Overcooking destroys much of the folic acid and thus contribute to the folate deficiency in man. The folate deficiency has been reported in babies given milk food subjected to heat sterilization. Requirement: the body stores of folate are not large, about 5 to 10 milligrams, and therefore folate deficiency can develop quickly. So the folic acid requirements are greatest in the condition when there is rapid cell multiplication, such as during growth in young children and during pregnancy. And folic acid supplementation during pregnancy has been found to increase the birth weight of infants and decrease the incidence of low birth weight babies. Deficiency: the folate deficiency may occur simply because of poor diet. It is commonly found in pregnancy and lactation where requirements are increased. It results mainly in a megaloblastic anemia. We will look into the megaloblastic anemia later. Glossitis, chelosis, and gastrointestinal disturbance such as diarrhea, distension, and flatulence. Severe folate deficiency may cause infertility or even sterility. There is also evidence that the administration of the folic acid antagonists such as alcohol, pyrimethamine, cotrimoxazole in early pregnancy may produce abortion or congenital malformations. So prevention: adequate intake of folate-rich foods such as green leafy vegetables, pulses, fruits should be given. Nutritional education and dietary counseling, avoidance of overcooking of foods, routine folic acid supplementation, and preconceptional folic acid intake in women, fortification of staple foods such as wheat flour with folic acid, screening for anemia in high-risk groups, early treatment of folic acid deficiency, and integration of folic acid supplementation program with the maternal and child health program. The next is vitamin B12. Vitamin B12 is a complex organometallic compound with the cobalt atom. The vitamin B12 cooperates with the folate in the synthesis of DNA. So the deficiency of either leads to megaloblastosis. Vitamin B12 has a separate biochemical role unrelated to folate in the synthesis of fatty acid in myelin as well. The physiological mechanism for its absorption requires intrinsic factor from the stomach, and the complex is absorbed only at the special site in terminal ileum. The sources of vitamin B12. liver, kidney, meat, fish, egg, milk. Vitamin B12 is not found in foods of vegetable origin. It is also synthesized by bacteria in colon. Liver is the main storage site of vitamin B12. About 2 milligrams of B12 are stored in liver, and another 2 milligram is stored elsewhere in the body. These stores are sufficient to tide over any deficiency for 1 to 3 years. Because of these reserve, deficiency of vitamin B12 appear to be rare, or the symptoms appears late. Deficiency. So again, vitamin B12 deficiency is associated with megaloblastic anemia or pernicious anemia, fatigue, pilar, peripheral neuropathy, numbness and tingling sensation, which is known as paresthesia, loss of vibration and position sense, ataxia, and subacute combined degeneration of spinal cord is also seen in patients with B12 deficiency. So again, the prevention from B12 is adequate intake of animal source food, because the vegetable diet has no B12 in it. Use of vitamin B12 fortified foods, routine supplementation for vegetarians and elderly, screening of high risk group, early treatment of malabsorption and pernicious anemia, lifelong B12 therapy where indicated, nutrition, education and awareness, and integration with the anemia control programs. Now we will look into the megaloblastic anemia. The megaloblastic anemia is a type of anemia which is caused by the defective DNA synthesis, resulting in large immature red blood cells or megaloblast in the bone marrow, and macrocytic anemia is seen in peripheral blood. The causes are vitamin B12 deficiency, folic acid deficiency, malabsorption syndrome, pernicious anemia, which is basically caused by the deficiency of intrinsic factor. The deficiency of intrinsic factor lead to the decreased absorption of vitamin B12, which ultimately leads to megaloblastic anemia. Increased requirements during pregnancy and hemolysis, and drugs which are interfering with the DNA synthesis like methotrexate and phenytoin. The clinical features of the megaloblastic anemia, the journal symptoms are fatigue, weakness, pallor, and shortness of breath, which can be seen in any type of anemia. Then gastrointestinal symptoms, which include glossitis, anorexia, diarrhea, and the neurological symptoms, which are seen mainly in the B12 deficiency, including paresthesias, gait disturbance, and cognitive changes. Laboratory findings and treatment. So when we go for a CBC in the patients who are who is presenting with anemia, we can see that there is increased MCV, which is suggestive of the microcytic anemia. Then on the peripheral blood smear, we can see hypersegmented neutrophils. We can also go for the serum vitamin B12 or folate levels, which would be low, and bone marrow would also show the megaloblastic changes. So this diagram on the right side is showing the normal blood smear, and the other one is with the megaloblastic anemia. And we can see that in megaloblast, the size of the cell is increased. There are large oval RBCs, and the neutrophils are hypersegmented. So the treatment of megaloblastic anemia is identify and correct the underlying cause, vitamin B12 or folic acid supplementation, and associated complications, they should be treated. The recent updates. This is an article which was published in May 2025, and it states that lower water-soluble vitamins and higher homocysteine are associated with the neurodegenerative disease. So the abstract is effects of water-soluble vitamins, vitamin B and C, and total folates have an impact on the cognitive and degenerative disease are mixed. So to investigate the role of soluble vitamins B5, B6, 5-methyl tetrahydrofolate, B12, and vitamin C and total folate in progression in patients with neurodegenerative disease. So in what they did in this retrospective cohort study, they enrolled 280 healthy controls and 646 patients who have a history of neurodegenerative disease. And the patients, they were classified into three groups. The patients with Parkinson's disease, the other group had the patients with Alzheimer's disease, and the third group has the patient with dementia. So they did the serum vitamin levels of B1, B2, B3, B5, B6, methyl tetrahydrofolate, and vitamin C. And they were measured via liquid chromatography, mass spectrometry, and total homocysteine and vitamin B12 and total folates were measured using electrochemical luminescence immunoassay. The serum levels, so they find out that the serum levels of vitamin B1, B2, B5, B6, methyl tetrahydrofolate, and vitamin C were lower in all patient groups than in control group. And the logistic regression results reveal that the lower levels of serum vitamin B2, B6, methyl tetrahydrofolate, and B12 were associated with the higher risk of dementia in Parkinson disease patient, and higher homocysteine level and low serum vitamin B6 and methyl tetrahydrofolate levels were associated with the higher risk of Alzheimer's disease related cognitive impairment. The level of vitamins were positively correlated with the neuropsychological assessment score and negatively correlated with the homocysteine level and stage of dementia. So the finding this suggested that the estimating water soluble vitamin level in older adult may be valuable given that they may help improve their cognitive function. Coming to the multiple choice question. So the first MCQ is, a child is fed with boiled milk without supplementation, develops bone pain and gum bleeding. Which mechanism best explain this condition? A, impaired iron absorption. B, defective collagen synthesis. C, reduced intrinsic factor. D, failure of DNA synthesis. Impaired carbohydrate metabolism.
B.
Yes, the right answer is defective collagen synthesis. The second MCQ is, a patient present with chronic alcoholism presents with confusion, ataxia, and ophthalmoplegia. Which vitamin deficiency is responsible? A, niacin, B, thiamine, C, riboflavin, D, pyridoxine, E, folate.
A.
No, the right answer is thiamine. It is a case of Wernicke's encephalopathy, which is because of the deficiency of thiamine, and it is a type of beriberi. Polished rice consumption in a low-income population is associated with the increased cases of edema and cardiac failure. Which deficiency explains this? A, plagra, B, dry beriberi, C, wet beriberi, D, scurvy, E, rickets.
C.
Yes, C is the right answer. So the polished rice, they become deficient in thiamine, and leads to beriberi. For prevention of the neural tube defects, folic acid supplement should ideally be started at A, after delivery, B, in second trimester, C, at first antenatal visit, D, before conception, E, at labor.
B.
D.
Yes, the right answer is D. It should be started before conception.
B.
Yes, D is the right answer. The fifth MCQ is, a strict vegetarian presents with numbness, gait instability, and macrocytic anemia. Which vitamin is deficient? A, folate, B, niacin, C, vitamin B12, D, thiamine, E, vitamin C.
C.
No, the
C.
right answer is C. The causes of macrocytic anemia is either vitamin B12 deficiency or folate deficiency.
No.
And if the hint is that the patient is a strict vegetarian, so we know that the vegetables, they don't have vitamin B12 in them. Which is the most cost-effective strategy to prevent the B complex deficiencies at population level? A, injectable vitamins, B, individual supplementation, C, food fortification, D, hospital screening, E, specialized clinics.
C.
Yes, C is the
B.
right answer. C is the right answer, food fortification. The seventh MCQ is, a patient presents with the long-term metformin therapy, develop paresthesias and memory issue. Hemoglobin is normal. Which explains this presentation? A, iron deficiency, B, folate deficiency, C, vitamin C excess, D, thiamine deficiency, E, subclinical B12 deficiency.
A.
No, again, the right answer is subclinical B12 deficiency, because we know that the paresthesias, ataxias, and the cognitive impairments, they are strongly associated with the B12 deficiency. The eighth MCQ is, in a drought-affected rural area, the prevalence of the fatigue, edema, and paresthesia increased despite an adequate calorie intake. Which combined intervention is most appropriate? A, protein supplementation only, B, iron and folic acid tablets, C, B, complex fortification of staples, D, vitamin A megadose, E, deworming campaign. The right answer is no. The right answer is C again. There is fatigue, edema, and paresthesia is present, so they are hinting towards the B complex deficiency. The ninth MCQ is, a patient presents with the dermatitis, diarrhea, and memory loss. He consumes maize as a staple. Which biochemical role is impaired? A. Collagen synthesis, DNA synthesis, C. Tryptophan metabolism, D. Fatty acid oxidation, and E. Iron absorption. The right answer is C, tryptophan metabolism. So the people who consume maize as a staple food, maize has a bound tryptophan, so it leads to the deficiency of niacin. The last MCQ is a National Nutrition Survey shows adequate calorie intake but high prevalence of neuropathy and anemia. Which policy gap is most likely? A. Micronutrient fortification, B. Iron supplementation, C. Protein supplementation, D. Vitamin A program, E. Deworming coverage.
E.
The right answer is A. Micronutrient fortification. This is the key to MCQs. This is the official channel of Institute of Public Health where the recording of this presentation will be uploaded. And thank you.
Thank you very much, Dr. Ayesha, for a very nice presentation. The important parts that you have covered as per the anemia, megaloblastic anemia, the dietary sources, scurvy, the story of James Lind, and the other important aspects that has been covered, along with the public health importance of the subject. However, I must say that the WHO guidelines for the nutritional requirements, especially for the vulnerable populations and the age groups, adolescents, young females, and the pregnant females, as well as the old age population, kindly include some slides from this important aspect too.
Right.
Overall, it is a good presentation, and I must appreciate everyone who has joined it. And we missed Dr. Kamran. He is a very regular attendee of each class. I don't know what happened to him, and I would like Dr. Temia to please contact him and ask about his well-being. And thank you very
Yes,
much, everyone. Dr. Amna and Dr. Ayesha and Dr. Amna Zaman and Dr. Temia for joining. So thank you, everyone.
Thank
Thank
you
you so
so
much,
much,
ma'am.
ma'am.